All right, welcome to the Explainer. If you're a focused learner gearing up for your medical board exams, well, you are in exactly the right place today. Our goal is highly specific. We're going to master the absolute highest yield facts about human papillomavirus, or HPV. We are cutting straight through the noise and zeroing in on the exact pathogenesis, especially those sneaky E6 and E7 mechanisms, along with the strict vaccine rules and screening guidelines that show up on your exams time and time again. Let's get into it. So here's our clinical roadmap for this explainer. We're going to cover 1. HPV basics and viral tropism, 2. E6, E7, and viral oncogenesis, 3. HPV vaccines and immunization schedules, 4. Cervical cancer screening guidelines, and finally, 5. Managing genital warts. Okay, let's dive into this. Section 1, HPV basics and viral tropism. Because honestly, knowing what the bug looks like and how it actually behaves is the foundation for absolutely everything else we're going to talk about. I want you to picture the virus's structure right now. HPV is a double-stranded DNA virus. It's got an icosahedral shape, and this is key. It is non-enveloped. Now, while there are over 200 types of HPV out there, only about 40 of them infect the anogenital tract. But how does it actually get in? Well, it specifically targets basal keratinocytes. It does this by slipping in through microscopic tears in the epithelium. You'll hear this referred to as microtrauma. Now, a massively critical concept here is the lack of a viremic phase, meaning there's no viremic phase in an HPV infection at all. The virus remains completely localized right there in the tissue. I literally cannot emphasize enough why this concept is so highly tested. It perfectly explains the lack of systemic natural immunity. Because the virus isn't circulating around in the blood, the body mounts a really incomplete antibody response during a natural infection. We have to aggressively highlight the contrast here, because board examiners absolutely love to test your ability to differentiate these strains. Low-risk HPV types, specifically 6 and 11, cause about 90% of genital warts, also known as condyloma acuminata. And these have virtually zero cancer risk. On the flip side, you've got your high-risk types, like 16, 18, 31, and 33. These cause cancer, and HPV 16 is by far the most virulent of the bunch. To put some real numbers on that, HPV 16 and 18 together are responsible for 70% of cervical squamous cell cancers and an astonishing 90% of anal cancers. Moving on to Section 2, E6, E7, and viral oncogenesis. Consider this entire viral sabotage section a major previous year question, or PYQ, alert. We're shifting our focus to the exact molecular sabotage that examiners love to go after. So, when high-risk HPV infects a cell, it produces these early genes, specifically the oncoproteins E6 and E7. Your job? Know exactly what these proteins destroy. E6 degrades the tumor suppressor P53, and E7 degrades the retinoblastoma protein, or R. Let me give you the absolute best mnemonic to lock this into your memory forever. Pair the number 6 in E6 with the 3 in P53. If you just remember that 6 goes with 3, you will always remember that E6 degrades P53, which leaves E7 to degrade R. It's brilliant. And this breakdown right here, it's pure rote memorization gold. You want to treat this exact table like an attending is pimping you on rounds. If they look at you and ask, hey, what's the clinical result of E6 degrading P53? You don't blink. You just answer, uncontrolled cell cycle progression. And E7 degrading RB, malignant transformation. By destroying these vital cellular breaks, HPV basically gives the squamous epithelium a green light to transform into a malignancy. And this brilliantly illustrates just how long this whole thing takes. 20 plus years. That is the incredibly long latency period from the time of the initial HPV infection to the actual development of cervical cancer. This is not some overnight process. It's a very slow, insidious cellular transformation. But hey, here's a surprising and kind of reassuring fact to balance that out. 3 to 5%. That's it. Despite how widespread and incredibly common HPV infections are, only this tiny percentage of infected women will ever ultimately progress to cervical cancer, even without screening. Actually, most infections clear completely spontaneously within about 6 to 9 months. All right, Section 3, HPV vaccines and immunization schedules. With that pathogenesis fresh in our minds, let's look at our pharmacological shield. Get ready, because we're going to break down the highly testable rules surrounding the HPV vaccine. So the crucial point here is understanding what's actually in the syringe. All HPV vaccines are made of virus-like particles, or VLPs. They're composed solely of the L1 major capsid protein. They contain absolutely zero viral DNA. Zero. Meaning there is no way they can cause an infection. Because of this, they are strictly prophylactic. They cannot treat an existing HPV infection or prevent an already established infection from progressing to cancer. Right now, Gardasil 9 is the current preferred standard in the USA, covering 9 different strains. And medically speaking, you want to give this vaccine before a sexual debut for its absolute maximum efficacy. Now, the immunization schedule is incredibly strict, and it's based entirely on age. For younger patients, meaning those aged 9 to 14, it's a simple 2-dose timeline. Dose 1 is given at month 0, and dose 2 is given at month 6. Boom. It's really that simple for the younger demographic. However, contrast that with anyone aged 15 and older, or anyone who happens to be immunocompromised. For them, the timeline shifts to a 3-dose schedule. These patients need a dose at month 0, month 2, and month 6. Make absolutely sure you have these age brackets and their corresponding dose counts locked in your brain. Section 4. Cervical Cancer Screening Guidelines. Now we move forward to clinical surveillance. Just like those vaccine schedules we just covered, we have to memorize the precise age brackets for cervical cancer screening. Let's move to and see how this builds chronologically through a woman's clinical screening lifespan. At age 21, you start pap smears, period. This is regardless of their sexual debut. Then, from age 21 to 29, the standard is a pap smear every 3 years. And importantly, there is no HPV co-testing recommended here. Why? Because in this age group, HPV prevalence is super high, but the actual cancer risk is very low. Then, from age 30 to 65, the options expand a bit. You can either continue doing a pap smear every 3 years, or you can switch to a pap plus an HPV co-test every 5 years. But as always in medicine, there are exceptions, and you must flag this one. HIV-infected women do not follow that standard wait until age 21 rule. For these patients, you start cervical cancer screening within 1 year of their HIV diagnosis. Boards love to exploit this high-yield clinical exception, so definitely make sure it's top of mind. And that brings us to Section 5, Managing Genital Warts. We've talked a lot about cancer, but we also need to know the guidelines for managing these low-risk clinical manifestations. For treatment, you've really got 2 heavy hitters. Cryotherapy is going to be your safest, most effective, and least expensive option for penile and vulvar warts. But I want to draw your immediate attention to the anatomical contraindications of the second option, imiquimod 5% cream. This is a patient-applied topical treatment, but it is strictly for external use. I'll say it again, external only. It is absolutely contraindicated for vaginal, cervical, or anal lesions. This is a massive favorite for trick questions on exams, so please don't fall for it. I want to conclude today's explainer with a provocative clinical application question. We know that no treatment out there, not cryotherapy, not imiquimod, not even surgery, actually eliminates the latent HPV from the adjacent tissue. So how will this biological fact shape your postoperative patient counseling regarding recurrence? I'm going to leave you to think like a seasoned attending physician counseling a real patient on that one. Thank you so much for joining me. Keep studying smart, and I'll catch you in the next explainer.